ever since the simple primary health centers got upgraded to the first deferral units, we have realized that the knowledge of doing an ultrasound is extremely important because it helps to triage patients for several life-saving protocols and procedures. And therefore, without it, we really cannot move on. So it has now become a clinical tool more than anything else. Now, when we realize that, then we say, okay, if it is a clinical tool, then we have to have this kind of a knowledge, which we really have gained in abundance. We've had grassroots people talk to us, we've had experts talk to us, and we have realized that when grassroots people try and teach other grassroots people, then we get the best results. And the training that we have seen on site as well as offline has been absolutely fantastic. I want to congratulate the entire team led by Dr. Shama Kanungo and by Dr. Hasmukh for putting together such a program. And I know this will be the basis of all future training in handling clinical ultrasound throughout the country, and very correctly so. Today's topic is really something very, very important, and that is reporting. Because a report is important from 3 points of view. First of all, a report is a documentation of observations and a summary of the findings. So that is point number 1 and becomes extremely important. The second thing is that it serves as an audit in the future for your findings to see how correct they were. And third, it serves as a means of communication. The communication is of 2 types. One between the person who did the scan and then wrote it all down, and later on people who may also need to find those to use those scan findings. And of course, this aspect of having this access to the fact that in a medical legal situation, then this becomes a document that will be depended on. That, of course, is also equally important in these days of changing times, where we realize that a patient who is examined free of cost and a patient who is examined really anywhere in any clinical scenario is capable of moving into litigation, and we need this kind of evidence. And therefore, the importance of reporting. So I'm really looking forward to today's session. But while the session is going on and before it starts, let me congratulate the entire team, our friends at UNICEF, Sambit, for all the wonderful technology he has given us, and so patiently taught us how to use it. A lot of us were not familiar with such high-end technology, and he's been very patient. My thanks to him. And of course, to the wonderful ideas of our leaders, Dr. Kanungo and Dr. Hasmukh, for bringing us together and making sure that we serve our patients well. So over now, back to the session, the rest of the polls, and to the rest of the session. Thank you.
Thank you so much, sir. While the polls are going on, shall we stop the polls so that we don't waste time? How many have answered? 61% have participated because the post polls are important and we don't want to waste time because Professor Khurana's time is very, very precious. And so that once we finish the sessions, you will be asking him questions directly. So that I think we should start the sessions. Indira, are you ready?
Yes, madam.
Share your screen.
Yes.
Sambit, shall we stop the polls now?
Yes, ma'am, you can stop this.
Yes, because the post polls will be more important. And the first question is a bizarre answer. Most okay. So Indira.
Madam, my screen is visible.
Yes, your screen is visible. There's one red. Make it a slideshow.
Yes, ma'am. Is it
Yes.
now visible as slideshow?
Yes. Professor Khurana, you were not introduced to Indira. She's Associate Professor in Gynae obstetrics at MKCG Medical College, one of the 3 premier medical colleges of Odisha.
Congratulations to Odisha. Everything done.
The brilliant doctor,
What to do? What to do? Now I should
academician,
go in and learn some more. Because it is the God speaking. You know that.
yeah,
There are kings of ultrasound like Gustavo Malinga.
the
They're
last
the
session
God
is
of
her, last
ultrasound,
but
the
not
one
the
and only
least.
God of ultrasound. Yes, Ram.
And
Here I go.
we have introduced Indira to our participants in the last 2 sessions.
Talk is over.
Please mute yourselves. Okay. Indira, can you start?
Am I audible?
Yes, you are.
Good afternoon to all of you. Respected Shama Madam, Hasmukh sir, Khurana sir, Pahdi sir, my pronouns to all of you for giving me opportunity to be this learning project, to be a part of this learning program. My pronouns to all the senior members and good wishes to all others who have joined in this virtual platform of learning and teaching and learning. Probably this is the last session I am going to conduct. Maybe it is a last session. Perhaps the Odisha is seeing a better future, era of newer maternal child health care. What Madam Sama Madam, the divine dream she has conceived and she has now it has already delivered. I think the Odisha will see a new era of maternal and child health care with better improvement. Thank you, Madam, for your dream, divine dream that has come true. Since it is the last part, how to write a report. For last 6 months, we are observing how to diagnose a lesion and how to interpret our eyes are seeing the lesion and brain is used to interpret the what is the diagnosis. Now the most important thing is that what our mind interprets that has come to the pen and paper, that is the gynecological ultrasound report. The main objective of this session is to, at the end of this lecture, you all will be able to write a clear, concise, and accurate gynecology ultrasound report. Understanding of the importance of writing a good gynecology ultrasound report is necessary. And understanding the basic principles of gynecological ultrasound reporting is an essential part of part of the sonological examination. So, what are the key features of a gynecology ultrasound report should contain, and how can I make sure that I have written a good ultrasound report? That is the main today's discussion. So, what actually is an ultrasonogram report? It is a primary mode of communication between the patient, referring clinician, the sonologist, and treating physician. This is the communication that gives between all the 4 people. Is it important? Yes, as Sir Khurana sir has told that it is a medical legal document. It is not a plain paper. It is not your prescription. It is a medical legal document. A person may sue you on this document in future also. The aim of the gynecology ultrasound report to answer the original clinical question that is asked by the referring clinician, and you should give the proper information and you should regarding the patient management. It constitutes a clinical opinion of a sonologist and what the sonologist sees, the images he or she sees, and then they gives an interpretation which will helpful for the referring clinician for the better management of the patient. It should be clear, it should be concise, accurate, and should be logical. These 4 things should be a gynecology report should be there. While examining a patient gynecological, doing an ultrasonogram examination, the sonologist must think in three different ways. What he should do in before the examination, what he should look in during the examination, and what he should do after the examination. So before the examination, the sonologist must go through the referring clinicians. What is his clinical diagnosis? What is his clinical symptoms? What is her LMP? Why she has come to the hospital? And what is the clinical diagnosis of the doctor? Then during the observation, during the examination, he should do whether the clinical diagnosis that has been given by the referring patient and the observations he is doing, is it matching? Or any specific observation he has made during the examination should be reported clearly. After the examination, he will correlate what observation or what are the findings he has got during the examination, and what are the clinical diagnosis of the referring doctor, and should able to give a proper judgment and conclusion and diagnosis of the lesion. That is, so the sonological examination should consist of three parts: what you should do in the before examination, during the examination, and after the examination. So basic guideline for writing a report, it should be written by the issued by the sonologist performing the examination. He should write. Actually, the sonologist nowadays they're writing in the plain and paper, and the typist is typing. It should be the integral part of the entire examination. Only doing the sonography, and that is not the end of the story. You have how the whether the report has been clearly written and correctly written, and that should be checked by the sonologist, and that is the part of the examination also. It should be written as soon as possible after the examination is completed, or else you may get or you may forget to write some important finding in the report. The sonologist is fully responsible for the accuracy and content of the report, whatever written. The sonologist should be aware of their limitation and seek advice where necessary. If there is a limitation, if the patient is very fat, and there is acoustics is proper, there is bowel gas is enlarged and not able to see properly, then he or she should write it properly in this report and should seek necessary advice to get after a full bladder or after bowel clearation, or you can go for any other special investigation. This limitation and other what recommendation you are giving, it should be properly written in the report. It is mostly printed, but it can be written in also handwritten. But while writing, blue or black ink should be used. Red ink should never be used for writing a report. The date of the examination should be written, and signature and designation of sonologist should be mentioned in the report. Mostly there is a every center is having a pre-existing template and electronic database, and mostly people try to fill the database. Sometimes I have seen that somebody who had undergone cholecystectomy, and they have written a report the gallbladder is normal like this, because there is a pre-existing template or electronic database is there. So you should be careful while typing or while writing, and should take the proper care not to do any mistake. And it has to maintain the advantage is that it helps to maintain the consistency of reporting, and so that you can write all the you have examined the all the organs of the body and write the report properly, and allows the research and audit to take place if in future, and ensures adherence to the local standards. You now on your screen, this is a ultrasonogram report issued by some person. So there are so many lacunae there, starting from the not the properly legible writing, and it is not properly written in date, time, and center. It has not been mentioned. So it should not be like this. The report should be. So how the report should be? When we are discussing the ultrasonogram report of a gynecology ultrasound report, we should contain, this should be the format. At least under this heading we should write so that we will not miss anything in the report. So what are the things we should do in the uterus? You should go for the measurement. What is the three orthogonal measurements should be done? What is the volume? And if you any anomalies you found, then you should do. And also it is antiverted or retroverted, antiflex or retroflexed, or the mobility of the uterus should be mentioned. Coming the after uterus general examination, there are two parts to be examined. That is, one is endometrium and the myometrium. In endometrium, we will discuss in detail what are the things we should see for the endometrium and what are the things we should go for the myometrium. And if there is a presence of IUCD in situ, then it should be mentioned properly. The cervical length and the adnexal masses should be mentioned properly. So the reporting, the examination should be systematic, and the reporting should be standardized. That is the aim of the examination. So coming to the how to examination of the uterus, we have already gone through the all the classes of this recording uterus, but during how to report, that will only mention. First, the orientation, whether antiverted or retroverted. From your ultrasonogram picture on your screen, you have to decide whether it is antiverted or retroverted, or antiflex or retroflex, or mid portion of the uterus. Is there any axial rotation on right side, left side? Should be mentioned properly. What is the entire length of the uterus should be measured, anteroposterior diameter and also transverse diameter, so that you can calculate the volume of the uterus. What is the general echo texture or echo pattern? The echo texture, echo pattern should be the myometrum is the standard, and according to you have to measure what is the echo texture and say whether it is globular or elongated or any contour abnormality is there, and the mobility or sliding signs should be done. So coming to the examination of uterus, these are all things: orientation, position, size, shape, mobility should be mentioned in the report. The next thing, after the uterus, the next thing is comes to the endometrium. So for description of the endometrium, we have to follow the International Endometrial Tumor Analysis Consensus Group, that is IETA. This consensus, they provide us a terms, definition and measurements how we should take the term describe a endometrium. They have defined. So during the evaluation of endometrium, we should take the help of IAT consensus, and it should be systematic in examination, and reporting should be standardized. You can use a transvaginal sonography, but if the uterus size is more than 2 legs, it is better to do a transabdominal sonography. And if there is a cervical fibroid, sometimes you may go for transrectal, but TS and TBS will suffice for the evaluation of endometrium. If it is very large tumor abdominal mass, then you have to go for a TS. What we should evaluate in the endometrium? There are 5 major things under this heading we should measure. We should write the report. First, we will do the quantitative assessment, that is the measurement of the endometrium. Then second, we should go for the qualitative assessment, that is the echogenicity of the uterus. Then what is the Doppler blood flow in the endometrium? Then endomyometrial junction and other findings and pathology. On gray scale, this
I think there's some connectivity problem, network problem with me, Indira. Hello?
Madam, most probably Indira madam has hanged up due to network issue.
ପାଣି ପିଉଛି ହଁ ପିଉଛି ସେମାନଙ୍କୁ କଣ କରିছে
हसमुख सर आपण नहीं नहीं एटा पूरा इंदिरा पाल रो
कौन तो मैडम
नहीं will submit give the slides and you can start keep talking because Indira somehow gone out of the network. But we can see her slide.
You can see the slide. Yeah, this one she has completed or not yet?
No, she was discussing.
Yeah. I think this endometrium, I think we have already talked about it, and we should always use the terminology of IETA, that is International Endometrial Tumor Analysis. The terms and definitions must be used because what happens is when I describe a term, any other person who knows IETA will also interpret in the same way, in the same language. So it is very important that we speak the same language, and we have to mention what is the mode of examination we have used, whether it is transabdominal, transvaginal or transrectal. Transrectal we use many times in women, unmarried women, or some women who have problem in the vagina. There is some pathology which will not allow us to use TVS. So this is the mode of examination also we have to mention in the report. And if there are any limitation, what are the limitations, we have to mention that this was the reason why we could not assess it properly. So in, I think. Sambit Babu, I think she should be able to join again.
Sir, I guess, good afternoon, sir. Sir, I guess Indra madam has
Yeah, she is there. She is there. She has
introduced some
come again.
modifications to the PPT,
Uh-huh.
the original PPT. So
She has done a lot of changes herself. Yeah, it is also desired. She did it in a
She
nice
has
way.
joined again.
Yeah, she has joined.
Share
Indra madam,
screen.
apna join karantu slide.
madam, आउथरे share करंतु slide.
एटा स्लाइड सर देखा जाउची कि इज इट विजिबल?
नहीं madam,
To
madam,
share
good
screen again. You get gone
सब
off.
share करंतु, screen share करंतु.
एबे देखा जाउची?
नहीं आसीनी मैडम, आसीनी.
अच्छा अच्छा ठीक अछि.
ଆପଣ ଲଗା ଆଉ ଥରେ ଲଗଇନ କରିକିରି ଦିଅନ୍ତୁ, ନୂଆ ଲଗଇନ କରିକିରି.
मैडम आपण खाली स्क्रीन टा शेयर करंतु, शेयर स्क्रीन ऑप्शन को जाई की जो
शेयर स्क्रीन करली.
आगे सिटी मैडम गुडाय ऑप्शन आसु आपनकर जतिटा फॉन्ट खोला दिबो स्क्रीन न पीपीटी.
आसील म हां ठीक है हां
आगे
एटा री ऑफिस कैसन करथिन. एबे देखा जाउची?
हां एबे आसीला आसीला.
हां सर मो एक कोठी देखा जाउ नथि सर एठी थिली ना कोठी थिली मो मजरे.
मैडम या
Next
प्रीवियस
one.
स्लाइड था
Next one.
एंडोमेट्रियल ट्यूमर क्लासिफिकेशन.
Next.
एठी अछि. नेक्स्ट.
Next.
Next
Eight, eight,
This
madam.
one.
here.
This
एटा
one.
एटा सर
It is just ये हसमुख sir एटा discuss करूथिले. You can also start from here.
While examining the endometrium, we should follow the International Endometrial Tumor Analysis Consensus Group. They have provided us. They have given provided a basic idea regarding how to different what are the terms to be terms should be used for the definition and measurements for the evaluation of the endometrium. Regarding the evaluation of endometrium, we should do 5 things. One is quantitative assessment, one is qualitative assessment, one is Doppler and endometrial junction, and other findings. If there is a suspected, if the endometrial thickness is more than 40 millimeter and you suspect a polyp, then you can go for sonohysterography by injecting saline or gel into the endometrial cavity. On gray cell, when you are examining a structure that should be perpendicular to the beam so that it can be well seen. When you are using a Doppler, the structure or the flow which you want to see should be parallel to the beam so that it can be well seen. So the normal examination of the endometrial outline should be assessment whether it is visible or not visible. When the uterus is mid portion, then endometrial thickness may not be visible properly, but you have to do some movement so that it can be the beams will be parallel to the structure so that you can assess the endometrium. Whether the uterus is antiverted or antiplex, that should be written or reported. The thickness and appearance of the endometrium. Actually, endometrium has 2 layers, anterolayer and posterior. Each layer has a basal layer and functional layer. The basal layer is echogenic, the functional layer is hypoechoic, and the midline what we are seeing, that is the midline echogenicity. Then after this endometrial thickness, you have to look for the endomyometrial junction, and you have to report it whether it is regular, irregular, interpreted or not accessible, and any focal pathology, any fibroid or polyps should be assessed, and if it is doubt, you have to inject saline to better visualization of the polyp or fibroid. These changes in the endometrium is different in different phases of menstrual cycle. There are, if you consider there are 3 phases of the menstruating endometrium, the menstruating endometrium will be hyperechoic and complex. It is 1 to 4 millimeter in thickness. There is no subendometrial fluor just after menstruation. There may be some amount of blood or clot inside the endometrium. Then after 4 days, there occurs the proliferatory endometrium, that is from day 6 to day 14 of your menstrual cycle. We can see a 3-layer endometrium, that is echogenic basal layer. Then the mid layer is functional layer, that is hypoechoic, and the midline, that is the hyperechoic. midline is there. The thickness increases from 5 millimeter to 12 millimeter, 5 millimeter to 12 millimeter, and it reaches about around 12 millimeter, and the vascularity of the endometrium gradually increases. Then after that, the secretory phase that increases 7 to 15 millimeter and gradually becomes hyperechoic. In postmenopausal women, it is thin, homogeneous, and echogenic. So the not only the uterus changes its size and shape, and the endometrium changes its shape and size during menstrual cycle, also in different phases, periods of life. If you see the pre-pubertal girl, the ratio of the cervix is more broader and longer than the normal reproductive period of life. In the reproductive period of life, the uterus is more 2:1. Uterus is more longer than the postmenopausal pre-pubertal girl. And in menopausal women, the both uterus and cervix is 1:1. So here in the pre-pubertal girl, you have a long cervix, and in a reproductive period, you will have a long uterus, and in a postmenopausal uterus, you have a both uterus and cervix must be in equal size. So in reproductive age group, after delivery, it is increases size. The dimension is usually 7.5 cm, 3.5 cm, and 2.5 cm, and the volume is around 80 ml, and the uterus to cervix ratio is 2:1. In postpartum period, it normally increases size, and after 6 to 8 weeks, it becomes normal into size. So these are the changes in the menstrual cycle. This is first one is the post menstruation. The 3 layer is the proliferative phase, and just one before 1 day of ovulation, you clear cut you will have a 3 layer endometrium, and after ovulation, the secretory phase, the endometrium is thick, and there is the 3 layer endometrium disappears and it thickens. So in postmenopausal women, it is smaller in size, and the endometrial thickness mostly decreases to around 4 millimeter, and the body and cervical ratio is usually approaches to 1:1. So after the examination of endometrium, we will evaluate the myometrium. The evaluation of myometrium should be systematic, and reporting should be standardized. And this reporting, the concession has given by MUSA, that is morphological sonographic uterus assessment. So for myometrium evaluation, we usually use the MUSA consensus statement. It provides terms, definitions, and measurement of how to evaluate a myometrium. Similarly to the endometrium, we evaluate the myometrium under this following heading. That is, what is the quantitative assessment, what is the qualitative assessment, junctional zone, Doppler, normal variation, and other pathology. You can use your transabdominal, transvaginal, or 3D render coronal view also can be given. So to examine the myometrium, you should see for the overall myometrial echogenicity. Normally, we will consider the myometrium as the standard echogenicity, and it is homogeneous. And if it is more echogenic than a hyperechoic, if it is less echogenic, then it is hyperechoic. Presence of any diffuse or localized abnormalities or adenomyosis, then what is its size, what is location should be mentioned, and cervix should be looked for, and should be either it is normal or hypertrophic, or presence of Nabothian cysts should be mentioned properly in the report. Any abnormalities noted in the endometrium or myometrium should be reported using the IETA for endometrium and MUSA terms and definition for the myometrium. So coming to some pictures. Here, this is the picture how we should take the measurement of the uterus in 3 orthogonal plane, and you should take the fundus of the tip of this fundus to the external os of the cervix, and it should be in 3 transverse diameter and longitudinal section, and also sagittal section. If you can do a 3D render and view, you can see, if you have the machine, then you can see the endometrial cavity properly also. Also transvaginal sonography method, also you can take the measurement also. These are the some measure how to see the endometrium in the different views. Then coming to the echogenicity of the myometrium. Normal myometrium is the standard, and if it is hypoechoic, like in the first picture in the left side, that is hypoechoic, like in fibroid uterus, it is hypoechoic. If the myometrium is any lesion which is consistent with the other part of myometrium, that is isoechoic, or in the right corner, upper corner, if you see a lesion which is hyperechoic, as in relation to the myometrium, then it is hyperechoic. Sometimes a adenomatic uterus may have a hyperechoic or hypoechoic or cystic lesion. Then you can call it as a heterogeneous lesion. So you have to describe a lesion present in the myometrium as a hypoechoic, isoechoic, hyperechoic, or a heterogeneous according to the standard measurement, standard evaluation of the myometrium. That is the myometrium. What is the echogenesis that you consider is the standard, and as per that, the lesion should be described as a hypo, iso, or hyperechoic. Then again, what is the morphology? Whether the lesion is well defined, if it is fibroid and you see this type of lesion, this arrow marks, the lesion is well defined. Sometimes we see a lesion, but the margins are not well defined. Then we call it a ill-defined mass. Then after that ill-defined measurement, we can take the measurement of this mass. Then coming to the most common pathology you see in the uterus is the fibroid in the myometrium. So the Musa consensus statement also endorses the FIGO classification of fibroid. We know the FIGO has 8 different types of classification starting from 0, 1, 2, 3, 4, 5, 6, 7, 8. So according to, you have to mention what is the site of the fibroid. Accordingly, you have to mention. And not only what is the, according to FIGO classification, you have to mention what is the location of the tumor, because nowadays mostly everybody is doing a laparoscopy, and the patient, they want a topographic description of the myometrium where it is present, whether it is present in antral, postural, or upper corpus, lower corpus, or middle corpus. So you have to see the what is the site of the lesion, and it should be properly mentioned whether the present is cervix or right, left, middle, lateral. So apart from the FIGO description, you have to give the what is the exact location of the fibroid, and also it is better. Mala madam used to show that in her picture, pictorial description of the where the myoma is located. That will helpful for the surgeon to give the incision, where to give the incision. Next is third part is junctional zone. What is the junctional zone? Is the innermost layer of myometrium, what is adjacent to the basal layer of the endometrium. This is well visualized in the myometrium. The pink color is the functional basal layer. I have told endometrium has 2 layers. One is basal layer and is the functional layer. Basal layer is hyperechoic. Just basal layer, beyond the below the basal layer is the junctional zone is there. So this is the diagrammatic represented. The blue color says the inner myometrial wall. The pink color arrow shows this is the junctional zone. That is in a 3D rendered image. You can see the junctional zone also better, but in also 2D picture also, you can grayscale also, you can see the junctional zone better. This is adenomas is that presence of endometrial tissue inside the myometrium, and so this endometrium typically migrates from the to the myometrium from the junctional zone. So if you see any breach in the junctional zone, then that is a characteristics of the adenomyosis. So these are some pictures. Here you see a coronal 3D render image where the junctional zone is marked in the blue. That is the normal junctional zone. Here you see that there is a junctional zone has been breached and a mass is seen. And it is also not only in adenomyosis, in carcinoma endometrium also you can see there is a breach in junctional zone is there. So you can mention the junctional zone is regular. If there is regular in the right corner, it is regular. In the middle picture, the junctional zone in the blue arrow shows that it is not properly there. Then you can write the junctional zone is irregular. So in this way you can mention the junctional zone is regular or irregular. See, this is the 3D render image. Here the junctional zone in the left side is regular. In the left side picture, right side picture, the junctional zone is irregular. There is a adenomyosis diagnostic criteria. This has been proposed by Musa, that is Morphological Uterine Sonographic Assessment Group, and they have given it 8 transvaginal ultrasonogram criteria to describe a patient is having adenomyosis or not. Presence of 2 or more of these criteria are highly associated with adenomyosis. What are they? First one is the asymmetrical myometrial thickening. Maybe the anterior is shorter, the posterior has been increased. Presence of myometrial cyst, you will find cystic spaces inside the myometrium. Presence of hyperechoic islands in the myometrium. fan separate shadowing from the postural of or anterval of the myometrium, that appears like acoustic shadowing, echogenic subendometrial lines and bars, translesional vascularity. If you apply a color Doppler, then you can find that some irregular vascularity will be there, irregular junctional zone or interrupted junctional zone. If you find any two of these following criteria, then diagnosis AOB can be made. So this is right corner. You find there is a fibroid, and if you apply Doppler, there is a isoechoic lesion is hypoechoic lesion is there, and there is circumferential flow of blood. But in adenomyosis, there is intralesional blood flow is there, that is suggestive of the adenomyosis, and also you can see there is fan separate shadow, acoustic shadowing is from there, that is also suggestive of adenomyosis. So this is the Doppler, 2D Doppler, and it is a 3D Doppler glass body display of the normal vascular. The fourth thing that we should look for the Doppler for of the endometrium and myometrium, and there is a arcuate vessels are there that go perpendicular to the myometrium, and these vessels can be seen, and there will be some endometrial vasculation, normal vasculation during the secretory phase will be there. And this is the 3D render glass body display of the blood vascularity in the myometrium is there, and this is the normal. After the examination of the uterus, endometrium and myometrium, we should go for the pelvic mass. In last class, we have discussed how to examine adnexal mass and how to interpret all in detail. Just I'll touch that the most common adnexal mass that in a reproductive age group is a endometrioma. Well, endometrioma is a part of endometriosis. Endometriosis can be of 4 different types. One is superficial peritoneal lesion. Then second is endometrioma, that is the ovarian lesion, and endometriosis, where there is a collection of blood inside the ovary that leads to endometrioma. Then third is deeply infiltrating endometriosis, that is called DIE, and other is extragenital, that is presence of endometrial tissue in scar site or pulmonary or any umbilicus or anything. Superficial peritoneal lesions are difficult to diagnose by the ultrasonogram. It is mostly a laparoscopic finding. Endometrioma, that is ovarian lesion, can be a classical examination unilocular cyst with acoustic enhancement with diffuse homogeneous ground glass echoes as a result of hemorrhagic debris. And you can see a deeply infiltrating endometriosis by ultrasonogram with much attention if you can provide. If the patient complains of dysphagia and persistent discomfort in posterior compartment during defecation, you should look carefully regarding the posterior compartment, that is the rectosigmoid posterior wall of the uterus. There is a typical Indian headdress sign was defined as the presence of an adhesion between the anterior wall of the rectosigmoid colon and the posterior wall of the uterus. By pushing the probe gently against the side, it will be possible to see the stretching of the muscular layer of the ball, which may cause this Indian headdress sign. So this is the if you see this is the like this type of stripes are there, and you can see this is the typical kind of deep invasive endometriosis, which can be looked for if you will be careful. This is the endometriotic needle, and this should, if the symptoms is there, they should be referred to proper surgical surgeons for the excision of the deeply invasive endometriosis. Otherwise, the patient may not get cured. So while examining the adenosa, both the adenosa should be examined. Size of both the ovaries in 3 orthogonal planes should be measured. Number and particular pattern of the follicles were present, and is it corresponding to the phase of menstrual cycle, as the patient is reproductive period or postmenopausal woman should be mentioned. What is the mobility, whether it is there is adhesion to the posterior wall of the uterus or not, or to bowel or any pelvic side wall should be examined. Tenderness on pressure or by the probe should be examined, and fallopian tube is visible. Possibly, if there is a hydropio or hematosalping, should be visible and should be mentioned. Any abnormality, non-ovarian abnormality, NOA, non-ovarian abnormality, that also present in the adnexa, that should be also reported in the report, gynecology report. So when you're examining a ovary, we may get 6 different types of lesions. One, we may find a normal ovary, or may get a functional cyst, or may get a benign tumor. And whenever we have a doubt about borderline or invasive or metastatic tumor, we should apply the IOTA guideline to describe these things. These are some varied pictures we may get in the adenoma and should be interpreted as per the IOTA guidelines. And these are the hydro or hematosalping, presence of a cyst, unilocular cyst with incomplete septa, west side, the presence of diametrically opposite indentation along the walls of tubular cystic structure has been likened in the appearance of a human waist. The adenocystic lesion is positive waist sign is a tubular shape is considered pathognomony of hydrosalping, or there is a presence of hydrosalping is relatively common condition, and that should be differentiated from a ovarian cyst. Examination outline of free fluid ascites. Any small amount of fluid in the pouch of Douglas is considered as normal. Any fluid outside the pouch of Douglas is considered abnormal and should be reported. What is the amount of the fluid and ascites? It is a mild, moderate, or gross ascites should be mentioned and should be represented clearly. If there is a, it is anechoic, or there is some low level echogenicity suggestive of pus or blood should be mentioned in the report. Coming to the how to report the report should be a clear, consent, and you should use the present tense. In the language, you should use in the present tense, and should use with standard terminology and abbreviation should be used. You should avoid as much as possible any technical jargon, anything you know but it is not a common use should be avoided, and the report should be conclusive, and you must able to provide a specific diagnosis. And if it's not possible to give a specific diagnosis, like if you are seeing a ectopic pregnancy or any mass or adnexal mass, you should give a differential hemorrhagic cyst or corpusculum. You can give a differential diagnosis, and you may recommend then if you can do a urine pregnancy test or may go for a MRI, CT scan. You can give a recommendation, and the recommendation, action or recommendation should be clearly mentioned in the report, and you should be able to give a succinct conclusion of this report. If it is not possible, you must give a alternative explanation should be offered in the report itself. So this report should be the summary of your report should consist of a brief clinical history. What are the observations you find in the during examination? Interpretation of the findings you have done, description of the findings you have done, what are the structures you have done, and what conclusion you have made out of all these things should be mentioned in the report. The report should contain the name of the patient, surname, date of birth, husband name, and all identification, and the sonologist detail according name, designation, and also the number of OMC, Odisha Medical Council, or any medical council number should be there. Name of the chaperone who is present while examining. It is mostly important when a male sonologist is examining a female patient. It should be the chaperone should be present, who must be a female, and place of the scan, this where it has been done, the type of ultrasonogram machine, and what is the probe, is it a transabdominal or transvaginal, and the probe features should be mentioned properly. The examination method over whether it is transvaginal, transrectal, or abdominal examination should be mentioned, and the indication of scan, why the patient has been referred to by referring clinician, that has to be mentioned. Any limitation like body has a more fatty lady, or there is bowel, or if bladder is not full, you are not able to see all the things, should be any limitation we found during examination should be mentioned properly. And the basic history there, like her LMP, her last menstrual cycle, if says this is menopausal or postmenopausal, or using any contraceptive OC pill, or if a postmenopausal or perimenopausal regime, if she is using HRT or not. So the conclusion should be succinct. Report abnormal finding with likely diagnosis or differential diagnosis should be written, and you could suggest further investigation like CCT, MRI, or urine pregnancy, whatever you find you think, and further management you should do. I'm just going through a one case report. It's 37-year. It's a para 2 living 2 irregular presented with irregular vaginal bleeding for last 3 months. Her urine pregnancy test was negative, and the report came as per written, like uterus is activated, echogenic focus seen with a feeding vessel, normal appearance of both ovaries, no masses or fluid seen, and the conclusion as written in the report was ultrasound finding demonstrated in echogenic focus within the uterus with a feeding vessel. What can conclude? You should go for a checklist. But this size is concise or is very small, concise. No ambiguous terminal not used. No inappropriate technical language. Yes, it is not used. No irrelevant information given, not given. Limitations stated, not stated. Whether you are not able to see everything, it is not stated. Address the clinical question. Whether the why the patient has, whether the written POC is there or not, that is the clinical question that has been asked by the referring physician. This has not been answered properly. Abbreviation not used, conclusive report not possible, and only the finding has been given, not the conclusive report has been reported. So this is not an accurate report. So again, what else has not given? The measurement of uterus has not given. The measurement of the mass or the echogenic focus, that has not been given, and a differential diagnosis or any suggestion or recommendation like urinary pregnancy, anything to be done, not has been mentioned. So this is not a proper report. Coming to the second report, this is a postmenopausal woman, 50th year, presented to the referring physician as a abdominal pain and bloating, and she had an history of hysterectomy. So they have reported like this: the uterus is absent as hysterectomy is there, normal left ovary, the right ovary contains a complex mass. I have already told, discussed in my previous class, a complex mass has no meaning. You have to define a mass as per the aorta, and what is the size? Is it unilocular, multilocular, unilocular solid, multilocular solid, or solid mass? Like this, you have to give a morphological classification of mass, no free fluid in the pelvis. So you have written a complex mass in the right ovary, but as we discussed, a mass should be properly defined and properly should be measured, and suggest referral to gynecologic rapid access clinic. So concise is okay. What is limitation not stated? The conclusive report is not possible and it is not accurate. The measurement has not been given and does not give a differential diagnosis. So this report is also inaccurate. So how should be the report should be? We have a corrected report, transvaginal. You have given the probes number, size, you perform with a verbal consent. Good views obtained so that limitation are not there. The uterus is absent. The left ovary is visible and measuring 10 into 15 and 18 mm is mobile, appears quiescent and compatible with age as the patient is postmenopausal. The right ovary contains a smooth multilocular mass. So she has given that this is a multilocular mass, 5 locules are there, measuring around 10 centimeter, 9.98 or 125 millimeter with what is the content? It is anechoic content. No present sign is visible. The lesion is mobile and non-tender. The aorta color score 1. So with this report, you can think that this is a multilocular mass and there is a content is anechoic and the score is aorta. Probably it is a benign mass. So no free fluid is seen. So suggest referral to gynec rapid. So the gynecologist who is seeing the report can have a differential diagnosis and manage the report and manage the patient better. So all these things you should, after doing an ultrasound, whether you should go for a checklist, whether this is report is concise, whether any ambiguous terminal has used or not used, any inappropriate technical language has been used or not, any irrelevant information is there or not, what are the limitations stated or not, address of the clinical question, why the patient has been referred to you for sonology, that has been addressed or not, abbreviation used carefully and conclusive where possible, and if it is not possible to give a conclusive report, you should give an action or recommendation for further investigation or management, and try always to give an accurate report. Thank you. Thank you, madam, for giving me the opportunity to share my views and this this gynecology report with all of you. Thank you, madam.
Thank you, Indra madam.
Thank you for a brilliant presentation. I would have preferred for you to go a little slowly when the cases were discussed. and expect an answer from the participants. So I hope still this has been recorded and to be shared with the participants, whether a report is, I mean, it corresponds to all the aspects that are expected from a report, whether it's concise, whether there's no ambiguity, whether inappropriate words have not been used and irrelevant information have been avoided, limitations, you have to state whether there were any limitation or not. And most important is you should address the clinical question which has been asked by the gynecologist or a clinician. And then, yes, abbreviations should be used carefully. And if you can conclude in certain lesions, you can directly conclude that this the type of lesion. But in some, when you cannot, you have to mention it. And so, throughout, you have to look at the accuracy. This is just what she has presented. Now, I would request Professor Khurana to give his expert comments and further clarify all the aspects of report writing, which Indira has presented. Indira, you can stop sharing your slides now.
Yes, yes.
Professor Khurana, are you there? Hello?
Ashok sir, are you there, Ashok sir?
Probably sir has logged out.
Okay, so yeah.
So then, Professor Hashmukh sir, you can discuss, or the case participants, you can put your question in chat box, or you can ask, unmute and ask directly. Hashmukh sir and Indira madam will answer. If Ashok sir just joins, then we'd be happy. Otherwise, we'll launch the post polls. Any questions? Any questions?
Indira madam, apna sharing tab kadi diyantu. Stop sharing karantu.
Share stop.
Share stop. Okay.
Yes.
Yeah.
Any questions?
See, writing a report is very, very important, and because after all, we are doing for some indication, and that particular indication, all the questions or all the answers to that problem, we have to express to the clinician. And sometimes we come across certain situations where we have to directly call the clinician and tell them, if I am a sonologist, I will, if I find something which is very, very abnormal or which is very, very important, then what is my duty is I will call the clinician and tell them that, okay, this is the patient and you have sent, and this is the abnormality I can see. And maybe sometimes the clinician also can ask something, then we have to clarify. But in pen and paper, almost all the everything has been depicted, as Indira madam has shown. All the relevant answers has to be there. It should be a concise report. You don't have to write very extensively. We don't write technical jargons, but whatever we say has to be crystal clear. We have to express our words very, very well. And sometimes, like as I think madam has shown, Indira madam has shown, we are not supposed to write complex mass anytime. We have to describe that, okay, this lesion is a unilocular or unilocular solid, or it is a multilocular or multilocular solid, or we have to describe. And I think we have the last two previous lectures has been very, very informative as regard the adnexal masses. So these are the questions we have to almost, our report should speak everything about the pertinent questions which the clinician wants. For example, if a patient is having has come to us with bleeding, say for example a postmenopausal woman, and we know that, you know, the postmenopausal abnormal bleeding is really, we have to exclude, especially the malignancies and some women who are having a lot of risk factors like obesity and all, we have to be very careful in examining them and giving a very, very clear-cut report and communicating also to the clinician, okay, this is the situation and patient needs a endometrial biopsy to rule out, because most likely she might be having, we can say that endometrioid carcinoma. So these are the things we can always discuss with the clinician, because after all, it is for the benefit of the patient actually. So this is, I had to say this. And any questions we can.
Padmalochan sir लिखचंती Indian red dress sign. Red Indians माने गोटे टोपी पिनंती ये जो फेदर रो टोपी पिनंती एंती ये करिकरी माने गोटे pointed है कि रहता ठीक माने परगुड़ा भलिया. So in a deep infiltrative endometriosis, there's a lot of repeated exposure to a hyperestrogenic state creates a kind of echogenic lines, which is extremely painful. It has sonographic, the probe tenderness is very, very high. And when you focus on that area, there will be a hypoechoic lesion. Supposing it's a rectovaginal lesion, there will be a hypoechoic area, and from that will radiate these. Indira madam, can you share that sign, red dress sign once more?
And those radiations will be always toward the bowel. And those radiations
only
are
for that the idea group has been formed.
Yeah.
Deep infiltrative endometriosis, infiltrative endometriosis group has been formed along with ITA. You have this other group. Idea is group by itself, because its treatment is very, very difficult. It needs very specific type of expert surgery, and not everybody can do it. It is, I think, Lisa, Manoranjan Mahapatra, and Subrat, and what's his name? Sujit. They are doing. And of course, outside you have Putambekar and other persons who are doing the deep infiltrative endometriosis in Kerala also. There are many centers in, I don't know, in Delhi also there will be several centers, but in Orissa, I think these are the ones who are doing laparoscopy.
Yeah, this is the one. This is the one. Yeah, this is the one. Deep invasive endometriosis. So here is the nodule, and then these are the spiky, the arrows which are pointing out. Those are the hypoechoic striations, and they are pointing toward the bowel. And it looks like the Indian red dress, I mean headdress, Indian headdress, Red Indian headdress. The Red Indians are original inhabitants of United States, and they wear these kinds of cap actually. They are still there. There are many areas where tribals, they live in that, and the government is really trying to help them. But see, there are, US has got a lot of diplomacy actually.
It's not like India, when you make a tribal, you're president.
Yeah, what happens is there actually what is happening is, this is my personal feeling, and I have seen that many areas which are tribal, there are not many good schools there, not very good clinic. America is not every part is very well developed. There are many areas which are far worse than our situation, because there are no facilities for them, and government by itself somehow do not want to let these people come to the forefront and get them developed. And drugs are introduced to them. They will keep, like even the Afro-Americans, you'll see very less percentage of those people
Same,
are-
same situation with Aborigines in Australia.
Yeah.
So these white people are not really sympathetic to other races. Anyway, this lesion can be there in rectovaginal, in between bladder and the uterus. In many places, you can find the same thing. Similarly, rectovaginal and in the pouch of Douglas. So when you find a probe tenderness, please go take little care and watch whether you can have this kind of whether you can appreciate this echogenic lines coming out from the hypoechoic area of the lesion. And what about the color picture? When you put color on this, what is the effect, Hashmukh sir?
This is a hypoechoic because there won't be any flow there. There will not be any flow.
These are the fibrotic bands, so they don't have any.
Fibrotic bands.
Yeah,
These
they
are
are mostly adhesions also, mostly adhesions
they don't
also.
have any. They don't have any blood flow. They are only
Yeah.
fibrotic things.
They are basically actually bleeding points. They are the endometrium endometrial tissues are there and which bleeds every month, and there are no vessels actually.
If she is in perimenopausal age and you cannot arrange surgery on these, hysterectomy with bilateral oophorectomy, and the ovaries go up, on low dose progesterone, then you can find some relief at our level, because the surgery is very extensive and
It is better to give a progesterone depot that will act for 3 months instead of giving a long time progesterone. Progesterone depot can be given, but the size of nodule is more than 1.5 to 2 centimeter. It is desired to be excised.
yes, it can. But if it is sometimes the colorectal surgeon will be required.
Yes, yes. It is a the colorectal surgeon should be the rectum. Many of the times the colostomy is required, or they simply close the rectum also when they are having a good study and this is better. But the nodule usually does not dissolve like a scar ectopic. Whatever you give, that is temporary. If there is a ectopic tissue in your scar tissue, the treatment is excision. Similarly, in the deep invasive endometrial, if it is very early, then it may subside with the progesterone. But if the nodule is there and there is all the features of the Indian head sign is there, all fibrosis is there, and the patient will have a discharge or discomfort in the lower abdomen, then it is better to do
surgery
it.
is definitive treatment.
Yes, madam.
So whenever we are writing a report, and if we say, okay, we have done only a trans-abdominal scan, then the clinician will definitely know that, yeah, actually DIE cannot be diagnosed by trans-abdominal route.
No, it has to be transvaginal.
Has to be devious.
Yeah.
Or it may require a transrectal.
May be required.
Yeah, sometimes it's transrectal, and also the fact that transabdominal it is, and also the sliding signs are very, very important because the adhesions will be always the uterus will be fixed, the ovaries will be fixed. Yeah, these are the things we have to.
Absence of sliding. Yes, now Sambit, shall we launch the post polls quickly? And all of you don't leave. This is the final session. Please don't leave unless you are bound to because of your some clinical responsibilities urgent. Please don't leave. Answer the post poll questions because each of them will be discussed in that. If you listen to that, then your report writing will be faultless, which is extremely important now. Now that you have undergone the whole course, you are now at a stage where you have to report what you have seen. So please, shall we launch the post poll, Sambit? And then please wait, because very important announcement will be made by Dr. Meena Som, our Chief UNICEF Health Specialist, and she will make two very, very important announcements. So please stay back. Yes, Doppler class will be held, but please stand by for important discussions, inputs, which will be given by Dr. Meena Som. So answer the post poll, and she will be coming in. She's in another session meeting. She has promised she will come in and she will announce the next two important components of this entire training program. So please answer the post poll. Don't leave. Don't leave. Don't leave.
Actually, today is the last session. There is not, we are not bothering you for a long time. I think it is a long time. We have been holding these courses for you. And
Right from January. Right from January. 8 months you have
yeah,
been.
actually, initially I thought, oh, how is it going to be possible?
So God has arranged. By God's sheer grace.
Yeah, actually, and with your,
So
you are
much
a
of,
divine, you, Shyama
no,
madam has a divine power.
no. Everybody has a divine insight. We have all made up of Panchakoshas, and the Anandamaya Kosha is the divine element in all of us.
Right.
So everybody is divine.
And
Nobody can be
of
outside
course,
the divine.
we will
Okay,
be
start answering, please. Answering poll questions only 0 or 1%. Why? Why after discussing, why did you the wrong answer? Oh, except, oh, tick. Sorry. It is right. Good, 100%.
Yeah. These questions should be very easy, actually.
Hmm.
Writing a report should be very easy for everybody.
You have to note that the 3 phases which was mentioned by Dr. Pal, Indira madam, before the examination, the inputs that you have to take from the patient and the attendant and from the referring doctor, and then procedure, and then the reporting.
Yeah.
So the procedure will be dictated as per the clinical questions asked. But your method will be as per guidelines, and your description of each of the structures is as per guidelines and the international analysis groups. So we all speak the same language. It should not be a henceforth the specialist of our state's report will be definitely superior to the ones who are doing private. Even private reports are very, very strange and funny. Many things are missed out. Many things are wrongly described. Useless jargon is used. So you people will be giving the best reports. You keep answering. When Meena madam joins, Meena madam's, if she is free, she will join. Otherwise, yes, quickly, all of you answer the post polls. This is the last post poll that has been.
I think for the next 3 sessions, we are not having any polling. So we will not bother you with this thing. But anyhow, I think that we have to now conduct that test, 50 questions, and then how much you have gathered from this training program.
Exactly. Meena madam will be talking about that exactly.
Right.
The online tests that you're going to have.
In fact, actually, this makes us more confident when we go through MCQs. It makes us more confident because we really know what is what, And MCQs are very, very useful for learning purpose actually. And here nobody is going to
IDEA
be
stands
doing
for
the I have made
Infiltrative Deep Endometriosis Analysis Group. IDEA, IDEA. So Indian headdress belongs to that, isn't it?
Please know all these terms. IOTA, IOTA, International Ovarian Tumor Analysis. So this will deal with all the adnexal pathologies. Then International Endometrial Tumor Analysis is all about endometrial terms and definitions.
Intrauterine lesions. Intrauterine lesions.
Yeah, and then idea is regarding deep endometriosis. Yeah.
Infiltrative.
Deep
Deep
endometriosis.
endometriosis.
Deep infiltrating endometriosis. And Musa, of course, is the myometrium. We discusses with the uterine myometrial pathologies. We learned about the mapping of fibroid with Musa terms. We had a very elaborate discussion. I think Dr. Ranjana Bhandari had done uterus and myometrium. In fact, these consensus statements have been formed because a lot of when they do research, because what will happen is they will have multi-centric trials at different centers. So terms and definitions has to be very, very accurate. Very accurate, because when I say something, when I say papilla, my other colleague in another country also understand what a papilla is. If I say a unilocular solid mass, my other colleague in another part of the world will understand what I mean by that. So these terms are very, very important, and that's why we also use in our daily reporting formats, so that when I write a report from Titlagarh and that case goes to Shama Madam, she will understand, okay, what do I mean by that reason. So writing this, participants, if you are looking at patients, can you mute? If you are looking at patients, please mute yourself. Yeah.
No, mute karo. Patient man kintu mute karo. It disturbance hochi.
Anima Kumari Sethi, ଆପଣ ଟିକେ mute କରନ୍ତୁ madam. Anima Kumari Sethi, can you mute please? Anima Kumari Sethi, please mute yourself.
Ambik, please mute everybody.
So yeah, that is how the terms, and these are very, very important for and I think when we have given all these consensus statements in the group also, and I had requested all of you to download and print it and read them, because they are very, very important. It is like learning a language, it is just like learning a language and the rules
Exactly.
of the.
Just as you have computer literacy, this is a type of literacy, ultrasound literacy.
Ultrasound.
Which is giving a new language.
Ultrasound is interesting with the thing that, what happens is, let us say, if I am an obstetrician and not doing ultrasound, then what happens is when I get a report from someone, well, I will not be able to be sure that what he is reporting, and sometimes the communication gap will lead to failure in diagnosis and management of those cases. And therefore, I specifically, I would request that every obstetrician, you please do your own ultrasound. And even if sometimes you are not doing, you must know the subject so well that you can interpret. And it will often happen that what happens is, if I'm a clinician and I am getting a report, and I will immediately know, okay, this report is not consistent with the diagnosis which I am making clinically. So you will always know, because as clinician, you have got a very acute sense of diagnosis. And if the report doesn't match it, then you will know that yes, there is something wrong. Either the sonologist has not performed it very well. And sometimes they ask for review. They will say, okay, please look at this again, and I am suspecting this. And many times it happened with me also, because when I was practicing in Titlagarh, I am practicing Titlagarh. Dr. Sujata Das, is she there in the group now? Dr. Sujata Das, are you there? So on 2-3 occasions, she has pointed out that, sir, this I feel that there is something you have not picked up. So she will send me the case again. So it will happen. It will happen with anybody. And that's why we are to look very meticulously and do it very carefully. So thanks to Dr. Sujata Das. Many times I would thank them that, okay, you have pointed out this, and then I will look at the patient again and give them a proper answer. Achanti, Sujata madam, Achanti? Many times this is my suspicion, and possibly
repeated abortion case re midterm samsa service ro length dekhi kuhantu a funneling achi ki nahi kuhantu koichi kethara.
Yeah. So
she's enjoying herself. Sujata and myself went to Dr. Suresh together for our basic training, that 15 days training in Chennai.
Right. So it will happen in our early life, many such experience I still remember, and I have learned a lot from those, my colleagues, my clinician friends. So the clinician, so Dr. Sujata has a very acute clinical sense. You will always, and now she is a good sonologist. She has become a good sonologist also.
रेफर करि परिबु नै सेटा पचारछि धर गोटे कन्फ्यूजन हला हम हायर सेंटर को
confusion actually lekhibo.
that is your it is required. It is required that you
and most important, all of us, if somebody has reported from Bhavanipatna and you are seeing that report at Balesur, please don't criticize the sonologist. Okay, don't criticize each other in front of the patient. Never we should do it. We are one family. We are here to see the interest of the mother and the baby and save them and improve the maternal and MMR and IMR in our state. And if you have any doubt, please call up the sonologist. I think if they mention the phone numbers also in a report, it would be very good. You can call up and clear your doubts, but never criticize any wrong findings or any doubtful findings. You can say that there is a doubt here, and I want to clarify with the respectful terms. Never criticize. He doesn't know anything. He is given wrong report. All these things, all these terms, we must never use in front of the patient, because we are one family and we are have to protect each other. Especially because this is a medical legal document, it is extremely sensitive. Okay, Sanjay sir, shall we stop the post polls and discuss the questions? because of some wrong answers. Sanjay, shall we discuss? Thank you, Sanjay, for
ଆମେ discussion
saying
କରିବା
every
ମ୍ୟାମ୍
session.
ଆଉ ଗୋଟେ ଜିନିଷ ମୁଁ କହୁଥିଲି actually reporting ଟା ଆମର ତ ଏଇ ଯୋଉ particularly ଯୋଉମାନେ report କରୁଛନ୍ତି ectopic pregnancy ରେ ଯେତେ ଯୋଉଟା suspicious ectopic pregnancy ଅଛି immediately concerned doctor କୁ ବା concerned hospital ର ଯିଏ ଅଛନ୍ତି emergency ଜଣେଇଦବା କଥା କାହିଁକି ନା ବହୁତ ସମୟ କଣ ହୁଏ ନା ସେମାନେ ମୁଁ ଗୋଟେ କେସ୍ ରେ ଦେଖିଥିଲି ectopic pregnancy ଲେଖା ହେଇଛି ଦିନ 10ଟା ବେଳୁ ପେସେଣ୍ଟ ଆଣିକି ରିପୋର୍ଟ ଦେଲା ସନ୍ଧ୍ୟା 6ଟା 7ଟା ବେଳେ So actually ସେତେ ଯୋଉଠି ectopic ସେଠି radiologist କରିଥିଲେ ତାକୁ ଦେଇ ଦେଇଛନ୍ତି and ସେ actually concerned ଯିଏ referral doctor କୁ ସେ report patient ଡେରି ଆଣିକି ଜଣେଇଲା ସେଇ କେସ୍ ରେ ସେମାନେ ଯଦି ଜଣେଇଦେବେ ଶୀଘ୍ର ଯିଏ sonologist ଥିବେ actually it's a case of ruptured ectopic so kindly take care ମାନେ at least ସେଟା verbally ଆସିଗଲେ ବହୁତ ଚଞ୍ଚଳ ଏଟା ବହୁତ effective ଜିନିଷଟା patient late କରିଦେଲା patient ଜାଣିନି what is the gravity of the situation ତେଣୁ ସେ କେସ୍ ରେ ରାତି 12ଟା ବେଳକୁ ଆମେ actually କଲୁ ବହୁତ difficult ରେ patient saved ଏମିତି ହୁଏ situation
ନହେଲେ ଆହୁରି earlier ହେଇଥିଲେ କେତେ loss prevent ହେଇପାରିଥାନ୍ତା
ହଁ ଆଉ ଚଞ୍ଚଳ ଆମେ
very pertinent point very pertinent
ମ୍ୟାଡାମ ୟା ପରେ କଣ ହବ ଆଉ
या परे एटा मीना मैडम अनाउंस करिवे सब्सिक्वेंट ये काम गुडा कोन हबो या परे plus definitely 2-3 sessions will be taken on Doppler and any of your if you want any clarification on any other topic
मैडम भलो सेटा गोटे डाउट क्लियरिंग सेशन बढिया रहिले हमें क्वेश्चन जार डाउट क्लियरिंग में पचारिबे आ जे थिबे
पोस्ट पोल हरके रहिबोनी प्री पोल पोस्ट पोल रहिबोनी ततरे फ्री इंटरेक्शन टा भी हबो कने बहुत लोक रिक्वेस्ट करचंदी डॉपलर ऊपर पर्टिकुलरली
मैडम
डॉपलर एडनेक्सल मास एडनेक्स मॉडल एगुडा सब तुम चाहू आउथरे सेउडा को करा जिवो किंतु वर्तमान पोस्ट पोल टा सारी देबा संबित हां मैडम
मैडम गुड आफ्टरनून मैडम एक्चुअली नेटवर्क इश्यू पे मो आर डिवाइस रो लॉग आउट हे जाई वर्तमान मझे डिस्कनेक्ट हे जाइली तो मु आ होस्ट नहीं हसमुख सर बे होस्ट अछंती तो से पोल एंड कर परबे आगे
ओहो हसमुख सर
अच्छा हां करि दउछि मैडम करि दउछि एटा मते पार्टिसिपेंट्स रो करिबा हबो ना
नहीं सर सर पोल ऊपर क्लिक करंतु लास्ट रे सेठी तळे गोटे राइट हैंड कॉर्नर रे एंड पोल रेड रो बटन आस्तबो तो सेटा क्लिक
एंड पोल कर देबी एंड पोल करिवि
आगे मैडम आगे सर
एंड वी डोंट हैव टू एनालाइज दिस एक्चुअली
सर सेटा एंड कला परे तापरे ऑटोमेटिक सेटा शेयर ऑप्शन
ओके राइट शेयर रिजल्ट्स नाउ
आगे सर
should I share results I should click on share results
आगे सर करते हैं
okay so yeah so we have done share results
question number 1
so I have to analyze this question number 1 was very easy one everybody has replied it rightly now D is the right answer and
94%
and my friends who have written it is a medical legal document we are asking for exception and exception is it can't be written by anybody it has to be written by the sonologist himself and it has to be written as soon as possible because if you don't write it immediately
म्यूट करो समझते म्यूट हसमुख सर समस्त म्यूट कर दियंतु
आगे Rajendra Sahu yeah I think yeah so point is if I don't write the report immediately I will always forget the small details and things will not be expressed very clear cut to the clinician so please know that we must make before we start the next before we start the next patient, we have to complete the writing of the report of the existing patient. So make sure. Question number, and 94% are very, very accurate, and all these answers should be very easy. 100%. You should everyone is expected to make the best of it. Question number 2. Question number 2, C is the right answer, because we did, our reports has to be clear cut, it has to be accurate and logical, but we don't write very, very extensive report. We write to the point, and all the necessary details should be in a concise way. We have to express everything and answer all the questions which the clinician is asking us. Say, for example, if I am describing that, okay, this is an echogenic focus in the endometrium, I am not expressing fully, because then I have to express it whether a feeding vessel is present, if it is likely to be a polyp, so it has to include, and if possible, most of us are not doing this injecting this sonohysterography because we are not doing it everywhere, but abroad, if you are there somewhere in US and you are practicing, you are supposed to instill fluid or normal saline and then look at the endometrium, which will be very, very accurate procedure. Without that, the procedure becomes incomplete. So this
in our facility, there won't be any time for doing this procedure. If you are interested, you can call the patient down in your free time and explain the details of the procedure, so that you want to have the clear-cut diagnosis. You can do it.
It is a simple procedure, but then what happens is we need
time-taking. In your busy setup, busy schedule.
Yeah, it is not possible. You have to give an appointment and do it actually. Right.
And it needs asepsis.
Right.
Perfect aseptic method.
So I think 86% of our friends have replied it right, that it need not be very extensive. Good. Number 3, question number 3, again, D is the question number 3. D is the right answer. D means all of the above is the right answer, because USG report is an integral part. Sonologist is fully responsible for the accuracy. Report should be written as soon as possible. So all of the above, D, and 98% of my friends have replied right. Question number 4 is, which of the following need not be a part of the USG report? Which of these should not be a part? Should not be a part of the report. And C is the right answer. They have made it highly, 92%. And because when we write a report, we need not include the USG diagnosis made elsewhere. So this is the right answer is C, and 92% of my friends have replied it right actually. Question number 5. A is the right answer, because it should not, we should write a simple language which can be understood by the clinician. We did not write very, very technical jargon in the ultrasound report. 80% of the participants have replied it right actually. Number 5. Question number 6. What are the things to be assessed by USG while examining the endometrium? D. Again, I think everything, all of the above is the right answer, because when we are examining the endometrium, we have to measure the thickness of the endometrium and the synchronicity with the ovaries, whether it is consistent with the ovarian function in a pre-menopausal or a menstruating woman. So endomyometrial junction is very, very important, because once this is disturbed, we think of adenomyosis. And in a normal person, this has to be a very, very clear zone, because myometrial region is hypoechoic and the endometrial borders are hyperechoic. That's why we can feel the difference. We can appreciate the difference. It has to be very, very regular, and it has to be uniform. So if it is not there, if it is not that way, then we suspect adenomyosis. So all of the above, and focal pathology, as I said, whether there is a fibroid or whether there is a polyp, So all of the above is the right answer to examine the endometrium.
100% have answered correctly.
100%.
Big clap. Good.
So question number 7, I think I have to reply now. My polls have gone. My polls have gone.
Question number 7. MUSA terminologies cannot be used to describe which one?
C is the right answer. Question number 7. C is the right answer, because when we are talking of MUSA statement, then for ovary, it is an iota terms. So that's why I cannot see this actually. Just wait, something is wrong.
You can't see the polls.
Yeah, actually more of screen time. MUSA terminologies means we know that it is a myometrial ultrasound assessment, and it cannot be used because we are talking of MUSA, myometrium, and for malignant ovarian, it has a different terminology, that is iota. So question number 7, C is the right answer. And unfortunately, many of my friends have not done it right. They didn't possibly understand the question very well. And 59% still have done very correctly. The CS scar, because we are talking of myometrium, and this basically the gap. CS scar is a gap in the myometrium. So again, MUSA will describe that. Adenomyosis, because it is a endomyometrial junction. It is a pathology of myometrium, because presence of endometrial tissue in the myometrium is not supposed to be there. And fibroid, of course, it is all about a myometrial pathology, and we have 7 different types of locations, the mapping, which was described by Dr. Ranjana Bhandari in a very, very elaborate way. So 59% went with the right answer.
It should have been better than 59.
Yeah. It is very simple, because when we are talking of ovary is not included in a myometrium. So please understand the terminologies very well. MUSA is for myometrium. IDEA is for deep infiltrating endometriosis. IETA is for endometrium. So the common consensus were formed, and this basically was for a research purpose, but then it could be adopted by any one of us for reporting. That's a language actually. It's a specific language to describe a pathology. So question number 8. Question number.
Sonographic features of endometrium
and intrauterine lesions are reported using which group? So question number, which group is definitely A is the right answer, because as I told you that for endometrium, it is IETA. Very simple. International Endometrial Tumor Analysis. For myometrium, it is MUSA, it is myometrial uterine assessment. IDEA is International Deep Endometriosis Consensus Statement. So these are the ways we have to know what the terminology means, and exactly there we are going to find all the specific terms. So A is the right answer, and 78%, yeah, 78% have gone with the right answer.
Very good.
Question number 9. Question number 9. Fully assess a large pelvic mass. Which of the following method must be used? Yeah, this is, I think this was very well described, but still 24% I am saying I am not very happy with this, because what happened, we had very clear cut, we had described that if a pelvic mass, let us say if you are looking at an ovarian mass, if we do a transvaginal, we can't reach the top of the lesion. So we have to do a trans-abdominal examination to see how far above in the abdomen. Many times we have seen lesion which extends up to the epigastrium, the bigger large cysts, you know. So the A is the right answer, but somehow I think my friends did not understand the question very well. A fully assess a large pelvic mass. Imagine a large pelvic mass will always go beyond the symphysis pubis, and therefore you and the depth, we had very clearly said that with transvaginal scan, because it is a high frequency ultrasound we are using, the depth is not more than 10 centimeters. So you cannot reach the top of the lesion, you can't see. So that's why many times we do a combined examination. We do a combined examination, and we do a transabdominal as well as a transvaginal. So, but without transabdominal, you cannot see a large pelvic mass. So that's the answer. And I think number 10 was very elaborately discussed, and I think this everybody should have. I would have expected more than 53%, because Dr. Indra had shown the slide. We repeatedly talked about this. It was the
And somebody asked a question and we went in detail regarding it.
But somehow I think I'm not happy. Red Indian, it is again, we talked that it is about deep endometrial assessment, infiltrating, because deep infiltrating endometriosis is such a pathology that I will tell you, many times in our earlier days when we did not have the access to the ultrasound, many women will say, okay, I am having pain. And when you look at them, many times I think you will think, oh, this is psychological. But actually the woman had pain because of the every month she will have bleeding outside the uterus into the peritoneum, and it will give them severe pain, and it will persist because it has gone to the peritoneum and the bowels, and we see a lot of nodules. Nowadays with ultrasound we are able to see it, but initial days when we did not have ultrasound, many times we could not help these people with proper diagnosis. We used to give them medicine somewhat for pain and all, but many times some people will also, oh, this is psychological, don't worry. So these were something, these are the things which has deep, and the Red Indian headdress are very well depicted and shown in the image also. So I would have expected 100%, but we have reached only 53. So not very.
Okay, now I think if you give the same question, it will be 100%, no?
I would have
yes
expected.
Or no, participants? Yes. Now
Yes,
please
yes.
stand by. Meena madam has joined. I would request Meena madam to kindly unmute and talk to our participants and what she has in store for them here to fore, and what she expects of them as well as the trainers, the mentors. Meena ma'am, hello. Sambit, is Meena madam free from the other meeting? She has
Again, madam, she has joined.
Yes. Meena madam, please. could
Ma'am,
you-
namaskar. Madam, namaskar.
Namaskar.
Namaskar, namaskar, Midna madam.
Sir,
Namaskar.
namaskar.
Let everybody see you also. We want to see your video. You have gone through so much of
Yeah.
pain in the last few months. We are with you.
Thank you, ma'am. Thank you for
In
your
spite-
kind support. Thank you so much. And I'm extremely.
We are always with you. We are always with you. We are
Thank
always,
you
you
so
are not
much,
alone.
Yes, sir.
For the
Yes,
entire show, you are the unseen hero.
sir. Ma'am, you are the hero. ଆପଣ ମାନେ
No,
ହସମୁଖ
we
sir,
are taking support on you.
मैडम पूरा चुटी फुटी कला फला कर देछंती हो काली जिबे बोली
Ma'am, thank you so much. My heartfelt gratitude to all the resource persons and facilitators to have taken so much of interest and pain over so many months. ମୁଁ ଏବେ just ma'am ବ୍ରଜେଶ କୁ କଥା ହଉଥିଲି ଯେତେବେଳେ ଆମେ ଭାବିଲୁ we will start in the month of January, we thought ଆଚ୍ଛା ଏତେ ଲମ୍ବା ଚାଲିବ, how do we manage? But then we have already reached the concluding session today. So we really am thankful to all the facilitators, each one of them from the national level, as well as Hasmukh sir, Apano, and all the medical college, Indira madam, and all of the facilitators. My heartful gratitude to each one of them, so that we'll be able to take this forward. I really expect that these learnings amku help karibo to take forward in terms of early identification of the high risk cases and how do we move forward on that. Referral केमती improve करिवा, management of complicated cases हमें improve टिके केमती करी परिवा, that is what we are looking at. As a next step, मु सुनुथिली there is a requirement for some additional sessions. We can work on that. And also हमें mentoring start करिवा to see and to provide that handholding support. हमें जो गुड़ा को सिखिले बे 7 मास धर की sir madam माने हमको इतने patiently सिखे चंती, how do we apply all that? How are we applying so that we see some change on the ground? The entire intent was जे आमे जदि एगुड़ा को करी परिवा ताले आमे ground level रे better risk identification करी परिवा, earlier risk identification करी परिवा, earlier referral करी कि आमे out in terms of outcomes will be able to improve the maternal survival as well as the neonatal survival. So that is our intent. So towards that, आमे as next steps आमे भाबु जे additional sessions जोड़ा को दरकार होची एबे सर भी कहूतिले बा रिक्वेस्ट अछि, we can take forward on that. Next होची हमें mentoring start करिबा. We already have a group of very interested mentors who are willing to give time, who are willing to travel. तो हमें mentoring start करिबा. हमें mentoring भी start करि परिबा. So these are two things which we can immediately do. And also we wanted to understand that a initiative re what has been the learning, कौन changes हमें आनी पारुचे. So that is one thing also we would like to document. And ma'am, Hasmukh sir, आपनो की इंदिरा ma'am की आउ जे भी हमारे सब एटी resource persons अच्छोंती, जहाँ भी suggestions अच्छी बा recommendations अच्छी, we are happy to take forward and take and move it. So there is no issue ma'am. जोटा भी आपण माने भाबु चंती हमें करिवा दरकार. The ultimate outcome is to save mothers and save newborns. So towards that end, जोटा भी हमें भाबु चे दरकार होची, we are happy to support all that ma'am. Thank you.
Meena ma'am, just one question, very important is UNICEF had, I think the additional director of maternal health had written to UNICEF to conduct an online test, which you had agreed right at the outset. So when should we have the test? After the one or two sessions, or straight away can we have the test? Because that timing will not be on a Friday. It will be, it has to be informed to all the FRUs that the tests are being conducted. You can inform the CDMOs so that their specialists will be attempting the online test to be launched by UNICEF. It will be online, so that right across the state we get the feedback on what the learning has been over all these sessions. So shall we give some time to the participants and
ma'am, 1 week time the baki, 1 week time the ba.
So participants, what do you say?
जहाँ भी participants कहिबे, mutually whatever is agreed, we are fine.
I think after 1 week we will be launching the letter will come from the directorate that an online test is being it is to be conducted, and the date will be also intimated beforehand, and UNICEF will be conducting that online test because they have the technology.
Ma'am, date एबे टिके समस्तंकर consensus नहीं जिबा कि कोन date suitable होची समस्तंकु
DFW करिबा DFW
नहीं हमरो participants मानकर convenience टा आगो देखिबा दरकार
ठीक है ताले से जो गोटे दिटा सेशंस माने रिक्वेस्ट करछन सेटा परे करिबा so after another 2 weeks time shall we give them 2 weeks time
Another 2 weeks.
they have been provided
2
all
weeks, madam.
huh?
After 2 weeks.
after 3 weeks
2 weeks. Girija Babu कहते 2 weeks. Girija
Yes,
Babu 2
yes,
weeks.
madam.
After 3
Two.
weeks.
3 weeks के कहला
मो सुकांती
सुकांती तू कोन पढिनु कि so 2 weeks let us strike a balance 2 weeks
Yes,
भितरे
true.
तो राति रे
नहीं आउ टिके पाठ पढिबा पाठ टिके पढि सारि दो
हां पाठ पढ आ ये पीपीटी गुडा सब तो दिया है तुम पीपीटी गुडा देखि दबो
हां तनु
oh Tapan is ready anytime even tomorrow he can face a test good so 2 weeks is the consensus according to Girja sir and everybody else 2 weeks
Yes, madam.
Madam, 2 weeks.
okay
2 weeks
good.
enough.
So Meena
Actually,
madam you
yeah, actually for gynecologists, all of you are gynecologists, and I think you, for you, ultrasound should be very, very easy because you are seeing lesions in live, you are operating people, you are looking patients live, you are looking at the pathology, you are looking at the lesions macroscopically. Only thing is you have to imagine that, okay, this with ultrasound, this should look like this. And you can very well, I think you should be, all gynecologists are expert diagnosticians in Europe. And that's because, you know, they have comparisons and they do ultrasound, not many, but many of them are doing. And that's why I think you are the best people to do it. And you should be the experts actually. And it is not difficult at all. And with that combination, you know, ultrasound is just one small part of diagnosis, but what you are doing is a wonderful job. You are actually handling all the critical cases personally. It is just not, you are not doing imaging. You are actually the saviors, and we want that with ultrasound, you make the best of the management. You can draw best management plan by doing ultrasound and saving mothers. And also beforehand, you can know what is going to happen. Let's say, for example, you can diagnose placenta previa earlier. You can diagnose a lot of pathologies earlier. You could diagnose malignancies very, very earlier, like ovarian pathologies, or many patients, you know, anemia is a big problem because many women are having excess bleeding and not having a facility to get an ultrasound, or sometimes they don't even go to hospital. So basically all that helps you is diagnose and clinically manage. And what you are doing is a wonderful job. Everybody, I see people working in periphery. I was also talking to Shama madam that we have one friend in Kesinga, very nearer to my place, about 15, 16 kilometers. He is after this course and he has been diagnosing anomalies. Imagine. So point is, and he's a very, and he says he's so busy with clinical. He's the lone gynecologist. Dr. Balram Sahu is a lone gynecologist in Titlagarh, but they do very good ultrasound. And with this course, it has been helpful to them, and it has sharpened their acumen for diagnosis also, and managing people earlier and diagnosing in early stages of the disease. So this is wonderful, and I really appreciate all of you because you are practically you are dealing with the patients every day. It is not imaging, but imaging will sharpen your acumen to diagnose things very early.
Okay, and then Meena ma'am, after 2 weeks, everybody, the online test will be done. So will you get in touch with the government, the DFW and additional director, and fix up a date?
Madam, next 3 days to ये अच्छी holiday अच्छी government holiday अच्छी. Next working day रे Tuesday ना madam मु office रे coordinate करके तपर आपन को.
Okay, okay. And then for next Friday, session ta ready karki, we'll share the PPTs with you. There won't be any poll questions, so that the few more sessions which the participants want will be covered. Okay.
Right.
So shall we end the meeting here?
Again, madam.
Preeti madam is out of station. She will be conducting the test. So we will. Yes, Devendra, thank you. It is really very gratifying to see that I don't know how we are really very happy. And particularly from my side, I thank from the core of my heart Hasmukh sir, who is the technical brain behind this training, and especially has chosen the right trainers for the right topics. That is amazing. Which particular which particular training session best? I don't know how he has that information. And Indira is now here with us. Indira,
I think the trainers themselves also selected the topics themselves, because they and I what my job was to help them give a lot of materials in terms of whatever I had before their sessions. I had shared a lot of details and how much they have to, because this is a basic program. So I had to tell that, okay, don't go for advanced. This is our limit. And that way,
good news today, Indira madam also has
she
offered
did
us
wonderful job. Yeah, Indira madam is an expert. She has been in Berhampur. She is very popular. She has a lot of followers, lot of students, lot of people are learning from her. I was taking feedback,
and
and
with
she has
being so busy, she has come forward also to go for on-site mentoring.
on-site training. Yeah,
that itself is so encouraging. And so definitely all of you should be in mission mode. The trainers, trainees, everybody, let us all be in mission mode for as Team Odisha. And definitely let us keep hitch our wagon to the star, which is we must have Kerala figures in Odisha. Nothing short of that. With missionaries like you, we are not in the Galwan border facing bullets. So if we just put up a little bit of strength, and we can achieve this goal. And in the next SRS, Odisha will show very, very good results. And with all this kind of amazing convergence of UNICEF with the directorate, government, and the private sector. Hasmukh sir is from the private sector, and he wanted to do something for his state, and this is really, God has shown him that this is the way you can help yours, not only Titlagarh but the entire state of Odisha. And so thank you all very, very much from the core of my heart. I always wondered, we have meetings in associations.
Thank you, ma'am. Thank you, ma'am. Thank you, sir.
Those meetings
Thank
and
you.
go back.
Thank you.
How much capability you get? No capability at all. It is we who have to go to you. And Vivek's and Meena madam's design of hub and spoke model of technical hands, technical knowledge going step to your doorstep is the answer. This actually caught my imagination. When that hub and spoke model was formed by Vivek, he has specialists before Meena madam, and now Meena madam has taken it right. Actually, Vivek couldn't materialize whatever he had a vision of, but Meena madam not only materialized it, but things got so nicely conveyed that we could take non-pneumatic anti-shock garments to your boots, to train you with that. We could do so many other things with this hub and spoke model. So that is the answer to improving things for the mothers. And so we are very, very happy for that. And definitely we are all one team. And we must go till the end and see that we have the best maternal outcome in whole of the country. Because the country has taken a precedent from our state. Our state should not fall in any terms. President of the country is from our state. So definitely our state should achieve the best. We'll make India proud. We'll make India proud. Okay. Thank you.
Thank you so much, Indira madam. Thank you, Meena madam. Thank you.
Big clap to
Sambit Babu.
UNICEF, to the trainers, to Hashmukh sir.
Sambit Babu, thank you so much. Sambit
Thank you,
Babu,
sir.
we have been bothering you for a long time.
So much
No, sir.
effort you have got.
Thank you, everybody.
And
Thank you, Sama Madam.
yeah.
Namaste, Pranam.
I also thank all my trainers, everybody who has contributed the presentations, lot of presentations, Dr. Pramodini, Dr. Indira, Dr. Ranjana, Dr. Preeti Dubey, Dr. Ajit Nayak, everybody, each one of them has done their job so brilliantly. So I thank them all, and my special thank goes to Professor Shyama Kanungo madam, because she saw something in me and say, okay, you have to do it.
And the idea is UNICEF. This hub and spoke. Actually, Meena madam is the real pathfinder.
Right.
That
So
hub and
when you said you have to do
spoke,
it,
I didn't know what to do. When I saw that hub and spoke model, and Meena madam was harping on creating experts who will go down for handholding, that was the thing which caught our imagination. It is originated from UNICEF itself.
right,
So
right.
the
Good.
entire thing, the credit goes to UNICEF.
Thank you so much. Thank you. And especially because what happened is Shyama madam has encouraged me too much that, oh, you do it. And then she acted like a coach, and I was the player and she has acted like a coach.
No, no, no. You are the coach. I was just throwing the ball back into the field by editing MCQs and getting everybody together. And national experts couldn't have come but for you.
Yeah. And Dr. Khurana, Dr. Chinmay, they have been very encouraging. Dr. Mala Sibal, and they also encourage us, and they were very happy with what is happening here in Odisha, because I don't think this type of program has been held anywhere else, nowhere.
The best certificate Hashmukh sir and Khurana sir gave us, because he said this is the best training program I have ever come across.
Right.
Suresh was doing something with the NHM help. And in Kerala, Hashmukh sir had mentioned something was being done, but not in the manner in which so actively the participants participated. And DFW initially had a doubt that can ultrasound be taught online. And so we have proven that we could, and don't worry, we are also coming on site. We'll be very, very happy. I wish I could go to every district. When my knees get a little better after another 2-3 months, hopefully I'll be able to go with all the groups. Hashmukh sir and myself.
World over, learning programs and the teaching programs have been disrupted by the new ways like Zoom platform, by these computers everywhere. I think this is the disruptive process they call disruptive class, because it is no more, we don't really need that every student goes to a classroom now. We are all connected with technology, and we can share our experience, we can learn, we can teach, We can express or consult. We can send our images. Lot of things. These things were not existing before, and after IT has come, after computers have come, this has become very easy way of learning. So virtual is the way today. Today is the learning program, sir. Virtual is the way of learning today.
Virtual and simulator also is coming.
Simulation, yeah.
Madam, NHM has promised to procure that for the state in the Center of Excellence.
बहुत जगह रे कोन करंती से माने एक्चुअली कंटेंट गुडा को तो रिकॉर्डेड थाए दे दियंती क्लास रे केवल क्वेश्चन पचारंती स्टूडेंट माने और कंटेंट गुडा को तांगर रिकॉर्डिंग थाए लेक्चर्स गुडा को प्रेजेंटेशंस गुडा को दैट दे listen to any time they are free. The only thing is what they do is when they meet in personally, they ask a lot of questions, whatever is their doubt, and that's a great way of learning. It is rather more attractive than the classroom, because in classroom they will listen only once, but if it is a recorded session, I can listen to it as many times as I want. And when my concentration is the highest receptivity, whenever I am at the highest receptivity, I listen to a lecture and remember it. Only thing is when we have a doubt, we have a contact with the teacher and then ask questions and clarify. So this is a new way. Actually, whole educational process has become completely different than what we had in our earlier days, actually.
Okay, shall we?
Thank you. Namaskar to everybody. All my participants.
Thank you, madam. Thank you, sir.
All participants are
All
more
participants.
important. Without you,
Without
we
you,
we cannot talk to a wall. You know, you are more important to us, and hope that everybody now
you are the real heroes.
more focused and more and when we come on site, again you can clarify all your doubts. We will demonstrate, we will show you, and anything you want to ask then and there, your doubts will be clarified. And even after that, you be in touch with your mentors, your trainer who is going on site. Be in touch with us, with them or us, anybody, and we will make a platform so that sometimes you raise a question, we will try to reply that. Thank you so much. Dr. Balram Sahu is there still.
Madam,
Professor Khurana's training program, he didn't give the.
Actually, I think he is not there. Otherwise, he has a training academy. I think we will post it in the group, and anybody who wants to learn, they can contact.
Professor Khurana's Mala Symbols, we can post. So anybody who is interested to still sharpen his or her capability, I'm sure everybody wants to do it, and definitely your services will be better.
Amara journal baharuchi Society of Fetal Medicine ro journal gote quarterly baharuchi.
Sabu state ro bhi program hochi, Josna madam bhi tankar koruchanti. That also, if you find time, it helps to learn from other experts. That also you can. I think many of our participants are joining that program, which is being joined by throughout the state, not only throughout the country, but also outside the country, people are joining that. So, okay. Goodbye.
Madam, all through these 28 weeks of journey, our participants have kept us motivated and encouraged.
Yes.
Madam, participation pai hi hame next week pai energy pautile. Madam, आउ हमर WhatsApp ग्रुप टा को जदी आउ हमें टिके इंटरेक्टिव करिया पई हमर जोटी भी एफआरयू रे स्पेशलिस्ट माने अल्ट्रासाउंड कला बेले किछि स्पेसिफिक फाइंडिंग्स पाउचंता जदी वीडियो रिकॉर्डिंग शॉर्ट वीडियोस करी के जदी ग्रुप रे शेयर करिवे सो दैट लर्निंग ऑफ अदर्स आ तांकर डाउट क्लियर भी ये पई तले आउ जे भल लागो आगे
करि पारिबे
टेलीग्राम ग्रुप टा करबे करो
नहीं मैडम WhatsApp ग्रुप एनफ अछि सेत्रे आगे
अच्छा ठीक है WhatsApp ग्रुप टा हमें एडमिन कंट्रोल करिचु मैं वीकली हमें तो को
मैडम नले से माने मैडम से माने नाले पर्सनली आपन को पाखु
Admin
फास्ट
control
शेयर
କାଇଁ
करंतु
କରୁଛୁ? ये गुड मॉर्निंग गुड आफ्टरनून आड़े
हाँ
सब
आगे
पोस्ट कर दियो।
मैडम पर्सनली से माने आपन को पाखु शेयर करन तापर आपन नाले ये कर
ग्रुप
परिबे
रे शेयर कले कोन एवरीबॉडी विल बी एबल टू सी इट.
आगे
It is
मैडम
okay. Because Hasmukh sir is group admin, he is giving very useful informations, and those who are doing some scans, if they want a clarification, they can put it in the group. But please request that don't give any other posts other than for learning ultrasound. Your own images or your doubts that you can post, but don't post good morning, good afternoon, happy Rakhi Bandhan, all those things. All
मैडम
those-
और any specific findings that they
yes,
encounter
yes,
with
very good suggestion, Sambit, because
Yeah, many times it can happen also that amara kona hochi dharantu some people I cannot do it for everyone, but many times you can contact your mentors, whoever is your mentor, like Sujata madam many times tankara live dekhanti se jetale scan karanti se mote live dekhanti WhatsApp re au pacharanti, so thare mane we are able to solve their difficulties also. So this is one way, but provided your mentor is free and not working, and of course means
ये Sambit, hello,
आगे मैडम
mentor list है जे district wise. Shall we
Okay.
share it in that WhatsApp group so that the specialist would know who is their mentor?
हाँ मैडम हे परिबो सेटा तो टेंटेटिव मेटा तापर फाइनल तो डायरेक्टर लेटर आसीबो
नहीं हाँ डिस्ट्रिक्ट वाइज फाइनलाइज हो जाई छै
आगे आगे मैडम
TOT टा हबो तापर the mentors will go to their respective districts, but
आगे
if we can post it in the WhatsApp group which mentor is for which district, then individually they can contact their
Connect.
mentors.
आगे मैडम
सेटा भी ଗୋଟେ
आगे।
ଭଲ ଜିନିଷ ହବ
आगे मैडम
जी मोर गोटे बजेट टे सैंक्शन हैला श्यामा मैडम,
हां
मोर गोटे बजेट टे सैंक्शन हैला, बजेट ता थिला मोर वाइफ कहला नै तुमे तो बे जीवो ऑन साइट, डोंट गो इन दिस ओल्ड कार, शी हैज written a check, she has written a check to buy a new car.
good car.
सर कांग्रेचुलेशंस
Thank
So
you.
what is the make? What is the make?
Yeah, for on site I think this is the gift she is giving me.
Good. So it's so nice to see you back healthy and feeling strong.
Right.
Okay.
How end
Sambit, shall
kariba?
we end the meeting?
आगे
Okay, thank you so much.
सर आपण एडमिन अछंती तो होस्ट अछन तो आपण एंड फॉर ऑल कर
अच्छा, I have to do it. Okay, okay. Thank
आगे
you
सर,
so much.
आगे।
Yeah, thank you so much.
थैंक यू
धन्यवाद. नमस्कार.
नमस्कार थैंक्स